It's a very simple thing, but quite now, if a patient has severe airway disease, there is always an involvement both of upper and lower airways. And quite often the patient is treated by the ENT surgeon or by the lung physician, but they don't talk together, they don't work together. So I think the biggest unmet need for a patient is the one airway approach, especially because most of the treatments work both on nose and on lungs. And I think especially for severe airways, it's for severe airway disease, it's really important that you have a combined approach where the lung physician and the ENT doctor work together, because then you have a chance of having biologicals, antibiotics, corticoids, surgery, many options, and you can do that in the best interest of the patient. So that is, to my opinion, very easy thing, but if you look at it, it's the most important unmet need for patients. And there it becomes interesting because you have several endotypes in severe airway disease. We have, for example, a late onset severe asthma, and this late onset severe asthma is quite often associated with chronic sinusitis with nasal polyps. For example, that's a clear type 2 disease with a lot of eosinophils IgE involvement. And we know there that biologicals are very effective. And so the allergy as such doesn't matter that much, but it's mainly this type 2 inflammation that is crucial for certain treatments like omalizumab, dupilumab, mepolizumab. That's the kind of biologicals we currently have. And the more we will go into this really biological treatments where you trigger or where you block IgE with anti-IgE, anti-IL-5, anti-IL-4/13, the more you will need to endotype your patient to choose the right patient. So I think that the treatment of biologicals, or the option of having biologicals, you need to endotype. Now, it's not always possible to take a biopsy of a lung or over the nose to see what a type 2 is. So we can predict more or less based on some other parameters like blood eosinophilia, blood IgE, but also the combination of polyps and asthma is most of the time, like more than 80% of the time, it's a type 2 disease. So I think endotyping will become more important the more we use biologicals. At this moment, we are still seeking very hard with biological treatments which patients benefit the most from a biological treatment. And the more you are type 2, like higher eosinophils in blood, the more that you benefit. We see that. So it's if you have eosinophils higher than 350, then you have a better outcome of some treatment. But also, for example, an asthma patient with nasal polyps, which is of course a phenotype, but it reflects to the endotype type 2, has a better outcome, has more effect of the biological if there is asthma combined with nasal polyps than without nasal polyps. So I think we have to do a better selection of the patient based on the endotype. So that's actually precision medicine we perform here. And we are slowly getting there. The problem at this stage is that you need a lot of data to find out what is the best response for the best patient. If we look to starting historically, we can start with anti-IL-5. Anti-IL-5 started off, I think, the end of the 90s. In the beginning, everyone was thinking it didn't work because it had no such a great effect on the FEV1. But later on, they saw in larger trials that it had an effect on asthma exacerbations. Also on nasal polyps, anti-IL-5 work. I have done the first studies ever done. And now there are bigger trials where they show that it works in certain groups. A second already long on the market product is anti-IgE, omalizumab. And there we know that it works very good for asthma. We also have shown, I showed that already 10 years ago, that it works for nasal polyps. Now we have a second trial showing that it really works good for polyps as well. So that are two established anti-IL-5, anti-IgE medicines, are two relatively established treatments for asthma, and now also evidence is there for nasal polyps. And nowadays we have one of the major breakthroughs, I think, is with dupilumab. It's an anti-IL-4/13 receptor antagonist, and this really tackles type 2 inflammation and has very good effects not only on asthma, nasal polyps, but also, for example, on eczema. So these are, until now, the biggest revolutions in the field. Of course, many new treatments are coming, but they are still in phase 1, 2, and 3 to get or to prove the benefit of the treatment. I think the biggest challenge for the world is the price. So the cost of the treatment is not small at this moment. However, if we see that we had many patients that were on long-term systemic corticoids, which is of course harmful on the long term. It doesn't cost much as systemic corticoid, but it really harms the patient. So I think we have to think not only in cost of the product, but also in cost of the side effect of the alternative. And the alternative is a systemic corticoid for severe airway disease. And there, if we end with diabetes, with osteoporosis, with severe vascular disease because of long-term treatment with systemic corticoids, I think we should come to the right selection of patients that have the most benefit. So I think in many countries we use, for example, one of the criteria is that patients should have had a history previously of systemic corticoids. I think this makes sense because then you select really the severe ones. So on the short term, we should go for those patients that have severe airway disease, where we know that we can have a benefit. And this is still where we are seeking which is the best patient for which treatment. Because it's so expensive, you don't want to have a lot of trial and error. On the long term, of course, I think when medication will get cheaper, I think in 5 or 10 years, that's always the case, the treatment gets cheaper, also because of competition, then you might extend to more patients that might benefit, but are not per se the ones that have a full-time need for systemic corticoids. So the biggest challenge is to choose the right patient for the right treatment, especially because the treatment is not cheap. But to my opinion, for some patients it's really necessary, and it saves a lot of money compared to the side effects of long-term systemic corticoid use.